So today we are treating a patient who has got lateral ankle instability. He's had it for 5 years. When did you first get this?
So it happened about 5 years ago. Playing football, I rolled over my ankle, and since then it's not been the same. It's kind of recovered in its own way, but like sometimes when I'm walking, my ankle would suddenly go.
So it just gives way while you're walking?
That's right, yes.
So this is really common. Now, lateral ankle sprains, so ankle sprains on the outside of the ankle, are the third most common footballing injury. It accounts for in total, about 48 to 50% of all sporting injuries. It's also got high reoccurrence rate, so people get a second injury. It's about 40% of people that get a second injury. Around 30 to 50% of patients get pain that lasts for 12 to 18 months. So they'll get swelling in their ankle, they'll get instability, like they'll just be walking like this chap is here, and it'll just give way on them. And they constantly feel as though the ankle's going to give way at any time. That can happen when, number one, it's not managed properly the first time you've had an ankle sprain. And two, if you've damaged multiple ankle ligaments. So if you come over here, let me show you a couple of ankle ligaments that this chap's got. So what he's done is he's torn his ATFL, which goes in that direction. He's got a partial tear of his calcaneofibular ligament, but his other ligaments, his posterior talofibular ligament, which is on the outside, and I'll just try and get it that way, is intact. We had to send him for an MRI to confirm that, because a ultrasound doesn't give you really good imaging. His anterior inferior talofibular ligament, which is up here, that's fine. And his deltoid ligaments, which is on the inside of the ankle, they're all right. So what we're going to do today is we're going to give this guy here, this patient of mine, a Prolotherapy injection. So he's going to have 15% hypertonic dextrose. So what we do is we get dextrose, which is basically glucose, and we mix it with local anesthetic, and we inject it in multiple areas in the ankle. Now, the way that this works is, this is a precursor to PRP and stem cell treatment, what a lot of people might have heard of. So this is the grandfather of all of them. And it causes an initial inflammatory reaction, then like cytokines come and repair within the area, and you get extracellular remodeling of the damaged ligaments. And that's how Prolotherapy works. Now, many of my injections I do ultrasound guided, but this one I'm going to do anatomically guided. So he's going to have multiple injections, and we're going to use 15% dextrose, as I said, around the lateral ankle. We're also going to provide him with insoles, which are the Dr. Foot Pro insoles, which are designed by yours truly. On his left foot, he's going to have a standard orthotic with this. It's got an arch support, a deep heel cup, and a pour-on heel cushion, which is great for multiple different conditions like flat feet and heel pain. But on his right foot, we've put a rear foot lateral wedge on the outside, a Dr. Foot 4-degree wedge, and a forefoot wedge, which is a Dr. Foot 4-degree forefoot wedge to control excessive motion, movements of supination. So when this goes under his foot like that, there, it's meant to be a 3/4 length insole, and it will prevent excessive motion. We've also given him some rehabilitation exercise, so he's going to be doing the STAR excursion exercise, which is a great exercise for ankle instability. However, after this injection, he's not doing anything for a couple of days. He's going to rest for the first 24, 48 hours. If he's got any discomfort, he's going to take paracetamol only. I don't want my patients to take ibuprofen post a Prolotherapy injection. Let's get on with the injection. So the way we test the anterior talofibular ligament is with the anterior draw test. So what you want to do is you want to go to the unaffected side first, and you want to move the leg in this direction. So you're moving it posteriorly like that. Then you repeat this with the affected side, and I can feel it give way. Now, if you just come forward a bit, you can also do the anterior draw test with holding the foot in this direction, and then you're actually pushing it anteriorly. So I feel that give way quite a bit. So that's the first test, and he's tested positive for the anterior draw test, which means that he's got ATFL, anterior talofibular ligament laxity, and I know from the ultrasound he's got a partial tear. You can also do a talar tilt test. So you ask the patient to push the foot all the way down, and you do that movement there. So you're going to invert the foot. Do you get any pain from that movement?
Yes, I do.
So there's pain from that movement, which is tested positive. Now, if you bring the foot up into an anatomically neutral position, you're now testing for the calcaneofibular ligament. So you can also get it into anatomically neutral position, and you do that test here. Any pain?
Yes.
Mild pain. Now, you can also put the foot into maximum dorsiflexion, and you're also doing that test from there. If you just come around a little bit so you can see where my hand is. So I've moved the foot into a maximally dorsiflexed position, and I'm just applying a force. Now, this is testing the posterior talofibular ligament. It's quite rare to injure the posterior talofibular ligament. I have seen it with MMA fighters and judo, people that do judo, but the most commonly injured are the ATFL and the CFL, which is the anterior talofibular ligament and the calcaneofibular ligament. The anterior inferior talofibular ligament, which is a high ankle sprain, which is also known as a syndesmotic injury, can also occur. This occurs a lot in basketball players. So you see these basketball players, NBA players, for example, they'll get this quite a bit. And other sports, so other sports where it can occur is like rugby or like NFL, where you're planted and then you're going to explode, and then you get pushed by an opponent, and that can lead to a anterior inferior talofibular ligament injury or a syndesmotic injury. Often when that happens, you also get pain here. So if you've had pain on the outside of your ankle and you've got swelling here, that's because this ligament here, which is your deltoid ligament, can also get injured. Okay, we are now ready for the injection. So we're going to use ChloraPrep, which is chlorhexidine, just to clean the skin, where we're going to inject him. So you're not injecting a lot. You're just doing multiple small injections. Now this is called the Hackett-Hamill technique. And the way this works is it's multiple fenestrations around the lateral ankle complex. Let's get to the calcaneofibular ligament, just like that. There's nothing actually wrong with doing anatomically guided injections. I think recently most of them I tend to do ultrasound guided, but anatomically guided injections are fine as long as you know your anatomy. So the patient has had the injection. Well, actually, he's had 20 injections, 20 really small injections using the Hackett-Hamill technique for Prolotherapy around the ATFL, which is the front part of the ankle, the calcaneofibular ligament, and the posterior talofibular ligament. We are now going to give him the Dr. Foot insoles, which with the lateral wedging that I spoke about earlier, and he's going to do the STAR excursion exercise. But for the next couple of days, he's going to take it easy. He's not going to do too much, and then we're going to do the repeat injection, because he's going to have a second injection in 4 weeks' time. So the way we do this is minimum of 2 injections. Sometimes the patient needs 3 injections, but we do a minimum of 2 injections, and we'll see how he is in 4 weeks. So I want to hear an honest review. How was the pain with the injections?
There was no pain at all, you know.
There's no pain at
There's
all?
no pain at all. I thought that I would be in pain. I'm sure you told me I'm going to be in some pain, but I didn't feel anything, to be honest with you. So, yeah, good. Thank you very much.
I have been doing it a few times.
Yeah, I could tell.
I've got better at it over the 30 years.
I could tell.
It's been an absolute pleasure.
Thank you very much, sir.